Good afternoon, everyone. This is Cherie Wilson, and I wanted to welcome you to this afternoon's webinar, Quality Healthcare for Lesbian, Gay, Bisexual, and Transgender People. And this is part 3, Clinical Skills for the Care of Transgender Individuals. Now, before we get started, I want to make sure that everyone's audio is working. So if you can actually hear me, can you push the little hand button so that I know that you actually can hear? Very good. I appreciate that. Thank you. So let's get started. So first, let me tell you a little bit about our center. The Hopkins Center for Health Disparity Solutions, which was founded in 2002 by Dr. Thomas Leviste, is a research unit of the Johns Hopkins Bloomberg School of Public Health. The center is funded by the National Institutes of Health, National Institute on Minority Health and Health Disparities, and it has been designated a National Center of Excellence in Health Disparities Research. We are very pleased to partner with GLMA to offer the third of this 4-part webinar series. So a few general housekeeping rules. If you experience any technical difficulties during the webinar, please contact GoToMeeting corporate account customer support at either of the numbers listed. And in order to have full audio capabilities, please enter the audio pen, which appears when you log into GoToMeeting if you are using the phone option. In addition, for attendance purposes, if you did not click on the GoToMeeting link that you received in your confirmation email, your participation or attendance is not registered. So make sure that you do go through that so you can actually be registered as being here. Otherwise, you'll receive an email after the webinar saying, sorry, you weren't able to attend because the system would not have registered you. And also, too, I want to thank all of you who have submitted questions prior to the webinar. We received lots of them. Now, some of the questions are actually beyond the scope of what will be covered in this particular webinar. Some of the questions actually will be covered during the webinar. And then other questions actually will be answered more fully during the presentations at the GLMA conference, which is being held in September, which Amy Wilson-Stronks will talk about in a little bit. So next, just a reminder that today's webinar is being recorded, and the speaker bios, the presentation slides, as well as the webinar recording, plus resources, will be available on our respective websites within 24 to 48 hours after the webinar. So just wanted to introduce you to a couple of things here in our center, and then I will turn it over to Amy momentarily. But part of the work that our center does is that we've created a suite of assessment tools for healthcare organizations called the Clearview Organizational Assessments 360. And so we have tools available for hospitals, medical practices, as well as behavioral health and social service settings. And in our tools, what we do is we provide an evidence-based, web-based cultural competency tool that evaluates the readiness of healthcare organizations to meet the needs of a rapidly diversifying U.S. population. Now, we take a very, very broad view of diversity. So we include not only race, ethnicity, and language, but we also include spirituality or religion, gender identity, as well as sexual orientation. And in addition to that, our assessment tools are based on national standards. So the enhanced national class standards that were just launched on April 24th of this year, the Joint Commission standards on effective communication, cultural competence, and patient and family-centered care. We also measure patient and client attitudes regarding patient satisfaction, discrimination, bias, and trust. We also use the Human Rights Campaign Healthcare Equality Index Core 4, as well as a modified HCAHPS patient experience survey. Next, I'd like to introduce you to the Culture Quality Collaborative, or CQC, and this is a network of leading healthcare organizations that is working in conjunction with the Hopkins Center for Health Disparity Solutions, as well as select cultural competency consultants. And our member organizations participate in webinars and have access to the members-only section of the CQC website. And these webinars provide members with the opportunity to learn, network, and share experiences as they develop and deploy various interventions to improve their organizational cultural competency efforts. In addition to that, our CQC members do use the various tools that I mentioned previously. And what we are trying to do is use these assessments to establish a baseline of performance. And then following the implementation of interventions, allowing time to scale and spread, we then try to reassess to determine the effectiveness of the intervention. Our hope then is to create an evidence base of cultural competency related interventions that could be shared nationally. Lastly, I wanted to bring your attention to an upcoming webinar that our center is hosting called What's New in the Enhanced National CLAS Standards, which will be held on Wednesday, July 24th, 3 to 4 p.m. Eastern Time. And as I mentioned, the CLAS standards, the enhanced CLAS standards, were launched on April 24th in Washington, D.C. I was very pleased to be in attendance with my research assistant, and our center director, Dr. Thomas Leviste, was actually on the technical advisory panel that developed those enhanced standards. So we will have Darcy Graves, who's a senior health education and policy specialist in the health determinants and disparities practice at SRA International, as our speaker. And what she will do is provide an overview of how culture and health are defined in the enhanced national CLAS standards. She'll talk about the target audiences and intended recipients of the enhanced national CLAS standards. The meat of the presentation will be what are the key differences between the previous and the current iterations of the CLAS standards. And then she'll provide an overview of the blueprint, which is a resource on how to actually implement the standards. And you will receive additional information about this in the follow-up email you will receive after this webinar. And now I'd like to turn this over to my colleague, Amy Wilson-Strunks.
Hi, thank you so much, Cherie. Thank you everybody for attending today's webinar. I am just so excited. A lot of work has been put into our webinar series, and I think each webinar is growing in its following. So I want to extend on behalf of GLMA, which is Health Professionals Advancing LGBT Equality, I would like to extend a warm welcome to everyone. And tell you a little bit about who GLMA is and what we do. GLMA is an organization that's mission is to ensure equality in healthcare for lesbian, gay, bisexual, and transgender individuals and healthcare professionals. GLMA is actually an interdisciplinary, multidisciplinary organization. We have members who are physicians, nurses, policy advocates, researchers, a broad array of folks who are all interested in cultural competence, health equity, and promoting LGBT equality specifically. A couple of the things that GLMA does and our members support are the national conference series that we offer every year, annually. It's the largest scientific health conference of its kind focusing on LGBT healthcare. This year's conference is going to be September 18th through 21st in Denver, Colorado, and there is information up on the screen about registering. I think we're going to hear some plugs for some interesting topics that are going to be addressed at that conference, because it really is able to share a lot of information about various things that are going on in terms of LGBT health and healthcare. So, also, GLMA provides resources for patients. We have the largest provider directory that's available that can be people who are clinicians and healthcare providers can sign up to be part of that. It's a great resource to share with patients so they can be aware of providers that are going to be sensitive to their needs. And also we provide an educational, patient education material called Top 10 Things to Discuss with Your Provider. It's a fact sheet series and actually served as sort of the foundation in some ways for today's webinar when we started planning our webinar for today to talk about transgender healthcare. I'd like to not waste too much time and begin to introduce our speakers, because I 2 years ago had the opportunity to hear Becky Allison speak. She was fantastic, and it was very, very interesting and a great learning experience for me. So I'm so happy that she has agreed to present today during our webinar. I'm also thrilled to have had the opportunity to meet and get to know Dr. Randy Ettner, who is our other speaker. And after working with both Becky, Randy, on developing today's webinar. I think Sheree and I both agree that looking forward to hearing everything that they have to say. Randy Ettner is a clinical and forensic psychologist practicing in Evanston, Illinois. She's chief psychologist of the Chicago Gender Center and is a WPATH board member. The WPATH is the World Professional Association for Transgender Health. She holds a diplomat and fellow status in clinical evaluation and trauma and has attended Northwestern, Indiana, Harvard, and Roosevelt Universities and Moray College in Scotland. She has written 3 books on transgender issues, including a medical and surgical text, numerous peer-reviewed articles, and she's an internationally syndicated columnist on women's health. She's the founder of New Health Foundation Worldwide, an organization that funds research and outreach on transgendered issues. Dr. Ettner has been instrumental in the passage of anti-discrimination laws and has provided testimony that helped establish legal precedent for the rights of transgender individuals in the workplace. Her efforts to secure appropriate treatment for prisoners with gender issues generated the creation of the WPATH Committee for Incarcerated Persons, which is a committee she chairs. Dr. Ettner has appeared on hundreds of television and radio programs, including Oprah, and as an advocate for the transgender community. I'm so excited that in addition to Oprah, she has decided to join us today. So thank you. I'd also like to introduce Becky Allison. Becky Allison is a cardiologist at the Heart and Vascular Center of Arizona in Phoenix, Arizona. Becky has been a GLMA member since the mid-1990s and has been a board member of GLMA since 2004. Currently, she's serving as past president of the GLMA board. She also is a member of the board of directors of WPATH, the World Professional Association for Transgender Health, and she's the past chair of the American Medical Association's Advisory Committee on LGBT issues. She's authored several book chapters on gender identity and was invited to speak at the 2009 American Psychiatric Association Symposium, In or Out, Gender Identity Disorder and the DSM. Becky grew up in the Mississippi Delta and received her BS and MD degrees from the University of Mississippi. She's trained in internal medicine and cardiology, and she's practiced in cardiology since 1994 in Phoenix, Arizona. I'm so excited to introduce both of our speakers. We have a great amount of information to cover, and while I know many people offered some questions and content they're hoping to hear, I think you're going to be really pleased with what we are able to cover today, and look forward to additional questions as we move along. I'm first going to turn this over to Becky Allison to have Becky go over some terminology for us, which is a brief review of some of the terminology that's been covered in our previous webinars. So without further ado, Becky, may I turn it over to you?
Thank you so much, Amy, and welcome everyone to our webinar. We've mentioned that the webinar series is loosely based on the series of documents available on the GLMA website called 10 Things to Discuss with Your Healthcare Provider for LGBT Individuals. We have separate 10 Things documents for lesbians, gay men, bisexual people, and transgender persons. And all these are available for your download and printing at www.glma.org. To begin with, I want to lay a little background with terminology here. This is not an exhaustive glossary of terms. It's only a few things that we're going to be using in today's presentation, and so I'd like for you to be familiar with what we mean by these terms. And on the slide, let's just start right in the middle, why not, and talk about gender identity. Gender identity is a person's intrinsic sense of being male, female, or an alternative gender. Gender expression is also a term you will hear, and this is the extrinsic appearance and behaviors which cause a person to be perceived as male or female. When we talk about the term transgender, it's had different meanings over the years, but as used in 2013, transgender is an adjective, not a noun, describing a diverse group of individuals who cross or transcend culturally defined categories of gender. A common characteristic of this diverse group is that their gender identity differs to varying degrees from the sex that they were assigned at birth. Now, many people who are in the transgender umbrella, if you will, don't have any distress. They're not unhappy. They're not uncomfortable in any way. But some are. Why would they be uncomfortable? Usually because of society's reaction to their gender identity and gender expression. The discomfort or distress that is caused by this discrepancy between a person's gender identity and that person's sex assigned at birth we call gender dysphoria. Gender dysphoria is a currently acceptable term for persons who are seeking help, whether it be medical or behavioral health help, for their transgender status. Those persons who do experience dysphoric distress will usually seek relief by making the life changes that we call transition. So gender transition is that period of time when individuals change from the gender role associated with the sex assigned at birth to a different gender role. Transition may or may not involve medical and surgical changes to conform the body to the sex that they were not assigned at birth. During this presentation, you'll hear me use the terms transgender woman and transgender man. And just to clarify, by transgender woman, I mean a person who has transitioned or is transitioning to the female gender role. By transgender man, I mean the opposite, someone who's been assigned female at birth but is transitioning to the male gender role. Finally, a caution that gender identity is not synonymous with sexual orientation. Like anyone else, a transgender person may be sexually attracted to men, to women, to both, or to neither, which is not always recognized. As one well-known transgender person has said, and I like this little quip, being transgender is not about who you go to bed with, it's who you go to bed as. And on that note, I will turn the microphone over to Dr. Randy Atner.
Thank you, Becky. Well, what is behavioral psychology? Psychologists no longer focus just on mental health and mental illness. They apply knowledge of the relationship between emotions, social factors, and biological factors to design interventions and to collaborate in healthcare delivery. Next slide, please. Well, why is this important? Why is there a need for a behavioral psychologist? Psychologists have always played a role in the care of transgendered people, and fortunately, the role of the psychologist has evolved considerably. I like to think that the focus has shifted towards empowerment. Psychologists work with individuals to affirm and consolidate identity, to remove barriers to care, and also to support the providers of care. Next slide, please. Transgender people are often estranged from family, and they may not have strong social support networks. In fact, transgender adults report twice as many incidents of discrimination and victimization as do gay, lesbian, and bisexual people. Stigma, victimization, shame, and untreated gender dysphoria can cause intense emotional distress. Psychological and emotional problems can be experienced as pain, or they're often implicated in the development of physical complaints or illness, and they can exacerbate existing disease. According to one study, 70% of visits to primary care physicians are based on psychological symptoms. But medical providers don't always have the experience, comfort, or time to assess depression, anxiety, or other problems that patients struggle with. It can really stretch the ability of any one professional to try to address every issue. Patients and medical providers can gain support from the input of a psychologist. Next slide, please. Collaboration of care between healthcare providers and behavioral health professionals is particularly important when working with transgender patients. For example, a survey of LGBT people with speech and hearing impairments revealed that the majority did not disclose their affirmed identity, even though they thought it was relevant to treatment, because they had had a previous bad experience, they had felt judged or had been discriminated against, and they believed if they disclosed, they would receive inferior care. So because transgender patients often require medical and surgical services, they must interact with a healthcare system that they distrust and that has been largely ignorant or dismissive of the unique issues they face. So many individuals forego routine screening or don't seek medical attention when they need it because they fear disapproval or discrimination. Trans men have reported difficulty accessing gynecological care in many parts of the country. One task of the psychologist is to work to improve communication between patients and providers. This includes encouraging accurate and complete reporting of histories and behaviors, and empowering patients to be proactive in obtaining information regarding procedures, protocol, treatment, and other aspects of their care. Next slide, please. But such communication is a two-way street. A recent study of 200 trans women found twice the prevalence of hypertension compared to controls. The researchers concluded that keeping a secret, often for decades, affects cardiovascular reactivity to stress. Both transgender patients and patients with hypertension have been shown to be less likely to verbalize problems or to ask questions of healthcare providers. So, if providers allow ample time and encourage the discussion of concerns, and especially if they initiate that dialogue, it sends a powerful signal that can override the impulse to minimize symptoms, and it may be as important as medication in the treatment of hypertension. We know that 40% of transgender patients report fear of accessing health care, compared to 13% of gay, lesbian, and bisexual patients. Poorer physical health, higher stress levels, more obesity than gay and lesbian and bisexual people, and less a likelihood to engage in physical activity are associated with being transgendered. This reluctance to verbalize problems, combined with the distrust distrust, and fear of the healthcare system by trans people results in a lack of screening, lack of preventive care, and often delayed treatment for illness. The overall result can be poor health. Next slide, please. While some clinics have sprung up that provide free or low-cost hormones, psychosocial support, and wellness promotion are often not available. And in many cases, insurance does not cover trans care. Many free or low-cost clinics also have a faith-based mission, which can create another barrier to care. Transgender people are 3 times more likely to report financial barriers to accessing healthcare when compared to the gay, lesbian, bisexual community. Next slide, please. If a provider is not part of an interdisciplinary team, the next best approach is to have a network of providers and programs that can address the concerns of the transgender patient. Of course, every person is unique, but there are some common concerns that often arise. First and foremost is family and relationships. Concern about the impact on loved ones and the fear of losing important relationships are problems that have serious health implications. Fear of rejection or the experience of rejection can be devastating. One young trans woman learned of her mother's death by reading the obituaries in the newspaper. Many transgendered people are parents themselves, and they worry how transition will impact the life of a child. And disclosure, having to explain oneself to others and perhaps educate them about gender identity can be very challenging. Some people dread telling a spouse, knowing that disclosure will arouse anger or worse. Coming out to parents, siblings, children, colleagues, employers, and others can wreak havoc, real or imagined, both of which are corrosive to health. Many high-risk behaviors are destructive means of coping that threaten health or contribute to disease. Smoking, substance abuse, high-risk sexual behaviors, or eating disorders can be successfully treated with cognitive behavioral approaches. And psychologists also often include mindfulness training and meditation in the management of these issues. Some people are so accustomed to feeling sad that they aren't aware that they're actually suffering from clinical depression. And anxiety can frequently be a component of depression. It's important to understand that depression affects many bodily systems, including sleep, digestion, and energy regulation. And untreated depression can lower immunity. Depression and thoughts of suicide are very common, and screening should be mandatory. Studies show that many individuals who commit suicide have seen a healthcare provider within the month prior to death. Healthcare professionals are often uncomfortable asking questions about suicide, but it can be a huge relief to feel that someone notices that you're in pain and cares enough to talk to you about it. Next slide, please. Hormones and transition can create sweeping life changes, and that can destabilize even the most well-adjusted individuals. Some transgender people experience a shift in sexual orientation. Providers can help facilitate sexual health by taking a sex history. Candid conversation and dialogue about sexuality is important in consolidating identity and resolving conflict. Referral to therapists specializing in sexual issues, if they are also knowledgeable about transgender issues, can be very helpful. And passing. The desire to present an authentic appearance in one's affirmed gender can be anxiety-producing. For some people, the fear of being read is a major source of distress. One trans woman with a deep voice became phobic about speaking. She wouldn't leave her home because she was afraid she would run into a neighbor and she would have to greet them. Everybody wants to be understood, and for some transgender people, isolation is a sad reality. Connection to others and a sense of community is an often overlooked area, but the spiritual life of a patient can play an important role in health. Many transgendered people have felt excluded from traditional communities of worship. One transgender person confided that if she had to spend another Christmas alone, she would kill herself. Knowledge of welcoming traditional or non-traditional belief communities can be a very supportive referral for people. This is a modifiable factor that has a huge positive effect on the health of people. And data shows that it's significantly associated in transgender people with better physical health, a lower likelihood of disability, and reduced depression. About 50% of Americans between the ages of 15 and 54 will experience a mental disorder at some point in their life. And occasionally a transgendered patient may present with a psychiatric diagnosis that also requires treatment. Bipolar disorder, schizophrenia, other disorders will require referral to a psychiatrist. But the presence of a psychiatric disorder does not mean that gender dysphoria cannot also be treated. Next slide, please. So as we embark on a new era in healthcare, these issues will need to be integrated into primary care settings. Education for nurses, physical therapists, and other healthcare professionals will need to include awareness of the needs of these patients in the educational curriculum. Acknowledgement of the social aspects of transgender healthcare and a blueprint for integrating these services will go a long way towards reducing harm and promoting health and well-being in patients who aspire to live authentically. Thank you. And now I'm going to turn this over to you, Becky. Hello?
Becky, are you able to?
Can you hear me now?
Oh, yes, very good. I think there was a slight delay.
Thank you. Welcome again to this part of the presentation called 10 Things Transgender Persons Should Discuss with Their Healthcare Provider. Randy alluded to the dialogue between provider and patient And this is so important when dealing with LGBT patients. One has to trust their provider. One has to be able to communicate and know that they're being heard. If the provider is knowledgeable to a degree about the transgender person's issues, then the dialogue will be so much easier. It's all about empowerment. Empowerment of the transgender person and empowerment of their provider, who will be able to render the appropriate care. Next slide, please. As a resource for this part of my talk, I would recommend the WPATH Standards of Care for the Health of Transsexual, Transgender, and Gender Nonconforming People. The 7th version has recently been made available online and can be viewed and downloaded from the website www.wpath.org. Next slide, please. This is one of several guideline books which are also available online. This particular guideline book is from the Sherburne Clinic in Canada, and it gives information that I'm not going to get into today, including specific drug dosing and information about surgical procedures. Next slide. The first step in receiving appropriate health care is getting access to a provider who is trained in transgender health issues. GLMA maintains a provider directory which can be a very valuable resource for patients seeking a provider who is both knowledgeable and supportive. Persons who cannot find a provider close to home may try to get information from support groups in their local area or from other online resources. As far as insurance is concerned, it's common for insurance policies to exclude transgender medical and surgical procedures. Much work is ongoing to bring about insurance reform, but we still have a long way to go. I would recommend to anyone who's able to attend the GLMA conference in Denver this fall to attend a skills building session on Saturday afternoon of the conference presented by Andre Wilson and Jameson Green. If those names are not familiar to you, they should be. These are leaders in the subject of transgender healthcare, insurance, and coding. The topic of their skills building session is trans insurance, coding, guidelines, and getting coverage. So this is just invaluable, and I highly recommend it. Closely related to insurance reimbursement is the issue of assigning appropriate diagnostic codes. Now, there are two sources for these diagnostic codes. One is the DSM, or the Diagnostic and Statistical Manual for Mental Disorders, and gender dysphoria, gender identity disorder, transsexualism have all been listed in the DSM for a number of editions. Now, the gender dysphoria is still part of the DSM, but it's being listed as a more medical diagnosis than a psychiatric one, and as such, the ICD, or the International Classification of Diseases, published by the World Health Organization, is in the process of revising its diagnostic criteria also to reflect the fact that gender dysphoria is a medical condition. Now, there's also the question of modern electronic health records, and you can imagine that in an electronic record there are check boxes, and one of those check boxes says male or female. That's it. And we need to modify electronic health records in some cases to allow for extra diagnoses such as male to female transgender, female to male transgender, or other. For example, if a transgender woman is undergoing an exam for the first time and the doctor is aware that this is a person who has undergone gender transition, they may think it's a good idea to examine the prostate and get a prostate-specific antigen blood test, which will absolutely not be allowed if the diagnosis is listed only as female. Conversely, a pap smear, pelvic exam are not going to be done for a person listed as male who's a transgender man. So coding and reform of electronic health records is an ongoing topic which we are very busily working on both in GLMA and in WPATH. Next slide, please. For many transgender persons, hormone therapy is the first issue they want to discuss with their provider. Before beginning treatment, it's important to perform appropriate history and physical exam to assess possible risks of hormone therapy. For transgender women, risks of estrogen therapy may be increased in persons with a history of venous thromboembolic disease, advanced liver disease, or abnormal lipids, especially elevated triglycerides. Now, I'm often asked, a person who's had a heart attack, a person who's had a stent put in, can they ever take hormones? Can they ever take estrogen? The answer is perhaps, with careful risk assessment and monitoring, because people who have been treated appropriately and are on antithrombotic medicines such as aspirin or Plavix have some degree of protection against the thromboembolic problems. People who have had pulmonary embolism or blood clots to the lungs are a more problematic group, and it's very difficult to advocate the use of estrogen in that category because it is such a high risk. Persons control the other risk factors, including hypertension, diabetes, and especially cigarette smoking, and a provider should always insist on a person's quitting smoking if they are going to be taking estrogen. The combination of smoking and estrogen significantly increases the risk of heart attack and stroke. Now, the most common forms of estrogen therapy are injectable estradiol valerate, transdermal estradiol by patch or gel, and estradiol tablets taken orally or sublingually. Most providers now prefer estradiol to Premarin or conjugated equine estrogens because of a perceived better safety record. Progestins include progesterone or Prometrium and medroxyprogesterone or Provera. Prometrium has less adverse effect on the lipid profile and is a preferred oral form of progesterone administration. Not everyone takes progesterone, but some persons feel that it gives additional feminization. Injectable progesterone in oil is sometimes used, but it can be very painful and is not a first choice. Other medications to reduce the effects of testosterone are primarily useful prior to orchiectomy. These androgen-reducing medications, or so-called anti-androgens, can be direct testosterone inhibitors, or they can inhibit the actions of brain hormones which act on the testes to produce testosterone. The most commonly prescribed androgen-reducing medication in the United States is spironolactone, which is a diuretic and a direct testosterone inhibitor. And I see people taking very high doses of spironolactone, which scares me as a cardiologist because I know that it can drop the blood pressure to low levels if it's not monitored closely. People taking this drug need to be monitored for blood pressure and also for serum electrolyte determinations because low sodium and high potassium are a distinct possibility with spironolactone. It's very inexpensive, however, and so it is an antiandrogen of choice in the United States. Other antiandrogens include the 5-alpha reductase inhibitors such as finasteride or Proscar or dutasteride or Avodart, and these are helpful in reducing scalp hair loss especially, and they are expensive compared to spironolactone, but many people prefer them because they are quite safe to take. The gonadotropin-releasing hormone agonists, such as Lupron, are in the news because of their reversible effects, and they are given often to young transgender people because they produce a so-called puberty blocking effect, and they're being given increasingly now to young preteens and early teens to avoid the effects of puberty both in the male to female and female to male population. Next slide, please. In the female to male population, the risk assessment for testosterone therapy includes blood testing, a screening complete blood count, looking for polycythemia or an elevated red blood cell count, which can be worsened by testosterone. Other things to look for are liver disease and cholesterol abnormalities, as with estrogen. Persons with unstable coronary artery disease may be at higher risk for testosterone administration and so should be stabilized as completely as possible before considering this drug. A special consideration for transgender men is the polycystic ovarian syndrome, which has increased prevalence in this population. The metabolic abnormalities of obesity, type 2 diabetes, hypertension, and abnormal lipids need to be managed carefully to reduce cardiovascular risk because testosterone administration may worsen all these abnormalities in polycystic ovarian syndrome persons. Testosterone is not given orally because of its potential for liver toxicity. It may be administered as an injection or as a topical gel. The masculinizing effects are similar, although more rapidly achieved with injectable testosterone. Testosterone administration produces deepening of the voice, which is irreversible. It produces beard growth and body hair growth, muscle mass growth and bulk, and scalp hair loss. So all these effects are masculinizing and will be achieved by the administration of testosterone. Next slide, please. Let's talk a little bit about reproductive health, because in the past people have transitioned and it's just assumed that, oh, I'm not going to have children, and that's not an option for me. But we're realizing now that there are indeed options for reproductive health for both transgender women and transgender men. Transgender women should be counseled about sperm preservation and encouraged to bank their sperm prior to starting estrogen therapy. And again, the reversible feminization in the young person using the gonadotropin-releasing hormone agonists may be preferable for young people because it can be stopped if this person does want to bank sperm, and then can be resumed again later once they have taken care of their reproductive health issues. Transgender men may want to talk to their providers about the rather invasive procedure of harvesting and freezing ova or embryos. Others simply stop testosterone and are able to become pregnant. I personally have some reservations about the effects of residual testosterone on a fetus, but no data is yet published to answer this question. These are the reproductive health options that remain open to persons at least in the pre-transition and early transition stages. Next slide, please. A topic near and dear to my heart as a cardiologist. As we mentioned earlier, oral hormone therapy may increase the risk of venous thromboembolic disease or pulmonary embolism. Estrogen also may increase the risk of hypertension and rarely type 2 diabetes, all of which are cardiovascular risk factors. Whether or not hormones are related to atherosclerotic disease, it is a fact that heart disease is the leading cause of death for both men and women in the United States. Many persons who begin transition in middle age, and there are many, may already have the beginnings of coronary artery disease. So I think it's a good idea to have appropriate screening, including a cardiovascular exam, EKGs, probably even stress testing for persons with other coronary risk factors like diabetes, hypertension, cholesterol, or even a family history of heart disease. A person who's had heart disease, as I say, is not completely excluded from the possibility of hormone therapy, but these people do require more thorough evaluation to detect and treat pre-existing coronary problems. Next slide, please. The question, do hormones cause cancer, comes up sometimes, and there's really no evidence to answer that, yes, they do. There have been very rare reports of breast cancer in transgender women. Usually these are found in people who took extremely high doses called stacking with combinations of injectable and oral estrogen over a long time. And there's such a small number that we don't have a statistical significance to say that yes, estrogen does cause cancer. It is a good idea to have breast examination as part of the physical exam to teach a patient to do breast self-examination. I don't think we have enough data to recommend routine mammograms for every transgender woman because the breast tissue growth that we see is mostly fatty tissue rather than the lobular glands. So what is more likely is that a person seeking health care is not presenting early enough until cancer is no longer in an early phase. And we've all heard stories about transgender people who were turned away from a doctor even though the transgender man had swelling and abdominal discomfort and was turned away until the ovarian cancer had metastasized. This is rare but certainly tragic. Although coding for these people may be denied by a binary diagnostic system that doesn't recognize transgender persons, it's still important to examine these organs physically as part of the checkup. Providers should be as thorough in cancer screening for transgender persons as they would for anyone else, including liver profile, colorectal exam, and not to be forgotten, a thorough skin survey, because sometimes transgender people do not want to take off all their clothes or to allow the provider to see the entire skin surface, but that's where skin cancers come from, and so it's up to the provider to request that examination. Next slide, please. Now, I hesitate to bring the topic up of sexually transmitted diseases because there is, in some circles, this inaccurate assumption that, oh, all transgender people are having unsafe sex and are at risk for HIV. That's not true. But neither is it true that no one is at risk, because transgender people are just like other people. Some are highly sexually active, and that means that they may be at risk for all sorts of STDs. One high-risk group are teenagers. And think about this. A young person comes out to the family as transgender and gets rejected, gets kicked out of the house, finds himself on the street, and doesn't know where to turn. Perhaps there's not a shelter, perhaps there's not a halfway house in that community. The teenager turns to the street, and the only way to make enough to afford the next meal is by sex work. And these are the people who are early infected with HIV, HPV, and the older recognized types of sexually transmitted disease. Another group is an adult who is a recent transitioner. They may experience a euphoria of finally living in their desired gender role, and they may want to experience sexuality in that role, forgetting the need for safe sex practices. A compassionate provider will take a sexual history from a reluctant patient, obtain the necessary information without casting stigma, and do an appropriate physical exam and laboratory tests for STD pathogens. Next slide, please. The risks associated with alcohol, tobacco, and drugs are similar to those in the general population. Tobacco use in particular is common in transgender persons, especially as an appetite suppressant to maintain weight loss. And we see this in both the transgender men and transgender women. It's very hard to get people to stop smoking when they say, I'll get fat if I stop. Elevated blood pressure, cardiac arrhythmias, and even seizures can result acutely from many of these agents. We're all familiar with the seizures that may result in a person with alcohol withdrawal, and the elevated blood pressure that can be both an acute and chronic effect of excess alcohol consumption. But we also need to remember that cocaine and methamphetamine are very high risk for cardiac arrhythmias as well as high blood pressure, and we've heard of persons in the news who have had fatal arrhythmias associated with the use of cocaine. Other drugs include the so-called club drugs like MDMA or ecstasy, which can produce a very rapid heartbeat in some individuals, as well as an elevated temperature, and energy drinks, interestingly enough, like Monster. I think you've heard maybe some things in the news about Monster being sued. This has over 20 times the amount of caffeine as in a standard cup of coffee. And yes, people, including transgender people, can be subject to the cardiac effects of these drugs too. So drug use is something that the provider needs to talk about a little and just warn of the risks involved. Next slide, please. This is a unique topic, and some of you may not be familiar with it. You may say, I've never heard of a person who's used injectable silicone. Well, it's a niche. It's used oftentimes in urban populations where people want quick fixes. They want the effects of feminization without having to take the time, the months and the years for estrogen to have its effect. And they found that the injection of liquid silicone into tissues will plump them up, distend them, and produce this rounded curve effect. Unfortunately, there are so many toxicities associated with the use of silicone. People have what they call pumping parties, where they pump you full, if you will, of the silicone, and a person uses non-medical grade silicone and very seldom uses a separate needle for every person that they inject. A recent news story told of a person arrested for murder after hosting a pumping party in which a transgender woman was injected in the buttocks with a large volume of non-medical grade silicone and died suddenly. Presumably, she experienced acute silicone embolism from accidental injection into a vein. Beyond the immediate risk, however, there are long-term risks of silicone, including migration. And silicone being liquid, it doesn't have to stay where we put it. It can go anywhere in the body. And liquid silicone injected into the buttocks may migrate down the legs. If it's injected into the breast, it may migrate down the chest and abdomen. And most especially if a person's injecting liquid silicone into the cheeks to get that cheekbone puffy effect, then the silicone may migrate down into the jaw and chin, and you cannot imagine how bad that looks. It just ruins a person's life and appearance. Removal is nearly impossible because it's droplets of liquid, and people have tried to remove it with surgical incisions, with syringes, but it's very seldom successful. The infections that can occur with shared needles, the dirty non-medical grade silicone, all combine to make this a definite forbidden practice and should be totally discouraged. And next slide. Randy had alluded to the fact that transgender people don't like to exercise, and I find this to be true. Persons may be self-conscious of going to the gym. They may not present the passable appearance that they would like to have, and they may be afraid of getting stares, remarks, and even physical threats. Whether or not such threats are founded, they are enough to keep a person inside, and by not going out, they sit at home, they have some more snacks, and they gain some more weight. So it's a vicious cycle. When we talk to transgender persons about diet and exercise, we try to find things that they can do at home if they are self-conscious about their appearance in exercise clothes at the gym. And after they have used exercise equipment at home, stationary bicycles, maybe a Wii, something to help them get fit, then they may feel better about themselves and be able to maintain their health. And we all know that exercise and maintenance of an ideal body weight is good for the metabolic profile, good for the blood sugar, the blood pressure, good for the lungs and the cardiovascular risk. So I've given you 10 things that your transgender patients may want to discuss with you and that you should try and discuss with them. And I thank you very much for this part of the presentation. And I'll turn it over to you, Cherie.
Great. Thank you. Thank you, Becky. That was great.
Hello?
So, yes.
Thanks.
Can you hear me?
Yes.
Yes, okay, great. And at the same time, let me unmute unmute all of our panelists here so that we'll all be able to respond. And also, too, we wanted to put a plug in for the fact Becky is very modest, but Becky actually was the author of the Transgender Top 10 Issues to Discuss with Your Healthcare Provider. So we just wanted to remind you of that again and to let you know that that is available on the GLMA website. So before we actually get into questions, because we have received a few questions, wanted to remind everyone that the presenter bios, the slides, the webinar recording, as well as a resource list, because we realize that Randy and Becky referred to several studies and resources, etc. So we will make that available on both of our websites. So about 2 hours after this webinar ends, you will receive an email and it will have a link to a webinar evaluation, and we would greatly appreciate and strongly encourage you to complete that, because we use that feedback to help us improve each of our webinars. And it also helps us with some of the subject matter and the topics. In addition to that, in that email, there will be links to both of our websites. And so, as some of you may have looked at the previous webinars, if you were not in attendance for webinar part 1 and 2, this webinar will be placed on those 2 websites as well. And then if you have any other questions after you receive that email, feel free to contact me offline, and I will try to answer any other questions specifically about the webinar you may have. So let me, we have a couple of questions here. And if you have other questions, feel free to go ahead and type them. Or if you do actually have audio capabilities, say you called in, if you raise your hand, I can also unmute you and take your call that way. Although that doesn't always work, so we can try it. And if not, then you can type in your question. So I'm going to start with one question that we have here is that, Becky, you mentioned the problems of electronic health records and how they basically have a binary male-female field, which makes it very difficult when we're talking about insurance issues and such. And I just wanted to put a quick plug in for UC Medical Center, because I saw an article or an email in the last week or so that stated UC Davis Medical Center uses Epic as their electronic health record provider. And they actually have worked with them so that they have included in their EHR gender identity as well as sexual orientation. So with that, I would think they would have included transgender as well. So I don't have the exact data fields, but I was very pleased to see that. So I didn't know if you had a comment with that at all, but definitely I think that's moving in the right direction. And it would be great if we could get those kinds of data standards so that people don't have to individually request those.
It is moving in the right direction, and WPATH has a committee, I believe Dr. Madeline Deutsch is the chair of the committee, that is working on recommendations for electronic health records for transgender persons.
Oh, excellent. That's very good to know. Thank you. So along the same lines, we had a question. So you were talking about how claims are oftentimes denied because if the patient is indicated as being male, but is now a trans woman, that the claim would be denied as a result. So we have a question of whether there are any efforts to educate insurers about transgender issues so that these claims would not then be denied.
Absolutely, and this is the focus of the skills seminar that Jameson and Andre are going to present at the GLMA conference. It's basically a ad hoc person to corporation type of effort to go to United Health, go to Aetna, go to Cigna, talk to them about their insurance policies for transgender persons and make them aware of the need to incorporate gender identity issues into their coding and health records. People have come up with some creative coding in past years, and some of that takes a bit of a risk. I think it's kind of hard to have a surgeon code for congenital absence of vagina in a person who was born male. But On the other hand, you can use endocrine disorder nonspecific and have pretty good success with that in many cases for hormone therapy.
Oh, excellent. Very good. Thank you. Now, this is one of the questions that came in prior to the webinar, but the question is, are there best practices for training navigators to enroll LGBT consumers in new health insurance options under the Affordable Care Act? So I can't speak specifically to that, except to say that as far as the health insurance exchanges are concerned, the Affordable Care Act does have cultural competency and health literacy requirements associated with the training of navigators. However, I personally haven't seen anything specific about LGBT being incorporated into that. And so if anyone on today's webinar is familiar with what their state is doing or anything at the federal level, if you would email me offline or type a comment in here, that would be very helpful. But if we are going to talk about cultural competency, it should also include this consumer and patient population as well. Great. So let's see. Oh, okay. A question came up. So Amy mentioned at the beginning that we have the GLMA directory of providers. So two questions related to this is, does the GLMA directory of providers include listings of mental health professionals, such as mental health professionals, therapists, psychologists, etc.? And Amy or Becky or Randy, are you aware of that?
I don't know about that.
Okay.
Absolutely, it does. Yes.
It does. Okay. Very good. That answers two questions. And then also,
if I may put in a little plug, Cherie, for a site that I maintain also, I have had a listing of behavioral health providers on the site that I maintain called drbecky.com, drbecky.com, listing of therapists, behavioral health care providers on a state-by-state, province-by-province basis, and people write to me and ask to be listed on that site. So it is a useful adjunct to the GLMA provider directory.
Oh, that's excellent. And that's a resource we'll also have to add to our resource list. Thank you for that plug. Very helpful. So we have some other questions that have come in. Let me just scroll in here. Let's see here. Okay. Okay, so the next question we have is, do either of you, and this might actually be more suitable for Randy, but what are your recommendations for initiating hormone therapy for a patient not concurrently receiving mental health care?
Well, people do not need to receive mental health care as a condition for receiving hormones. And I think that this is a misperception that many people have, that the psychologist is going to be the gatekeeper that's going to allow somebody to get the hormone therapy that they require. But that's a misperception, and many people do not need to see a mental health professional prior to receiving hormones. And I think the new standards of care make that fairly explicit, that a medical provider can give hormones to a patient if they feel comfortable in assessing the person's health status, and if they feel comfortable in working in that way, then there's not any longer a requirement that someone visit with a mental health professional prior to starting hormone therapy.
Great. Thank you for clarifying that, because it does sound as if that is a misperception. So thank you very much, Randy. That was very helpful. Now, we did have someone write in about the previous question about the training of navigators. Thank you, Ashley Whelan from Colorado. And Ashley said that in Colorado, One Colorado has been working with their exchange on training for navigators, going through the applications and cultural considerations. They've also been very open, and they actually have chosen 2 LGBT serving groups to be a navigator grantee. So that's very promising. I appreciate that clarification. And so maybe I'll add that as part of our list of resources as well, because that's a good example. Thank you. Ashley. So our next question, and they're coming in. This one is for whoever would like to take it, but the question is, are there specific engagement skills or techniques that work effectively with the transgender population in building rapport and trust?
I'll take that. I think that the most important initial skill is compassion. I think that too many times a transgender person has gone into a doctor's office and disclosed their status and are told, oh, we don't treat that kind of patient, or they're given a religious tract and encouraged to undergo some sort of reparative type therapy. These type of things can devastate a person who has taken time to work up the courage to see a provider in the first place. So all of the training won't matter if a person is not compassionate. On the other hand, all of the compassion will be appreciated but won't be as helpful if a person doesn't have some specific training. And I do recommend one of a number of books, and Randy may want to tell you about a book that she's written about transgender care, and these are excellent references for providers who want to know more of the nuts and bolts.
And I want to echo Becky's sentiments. I think that being respectful of people goes a long way towards establishing rapport. And you don't have to have all of the answers, but asking a respectful question, such as how would you like to be addressed, etc., really communicates a willingness to be a person's health ally.
Well, that's great. Thank you, Randy. I appreciate that contribution. So this question is for either of you, Randy or Becky. And the question is, are you aware of any research on the intersection of sexual identity development and ethnic identity development in transgender populations?
I am not directly aware of any such. I would use the term gender identity rather than sexual identity, but I think that we do have information about the various ethnic populations, Native Americans, persons from India, persons from Thailand. There are cultural traditions in many areas where transgender persons are an accepted part of society, but they do not have some of the opportunities that people in Western cultures do to complete a traditional or standard transition. So there are published articles about the Hijra, about the Two-Spirit population, but I don't think that they have gained widespread reading.
I see. That's great. Thank you. Thank you, Becky. Our next question is, oh, I'm sorry, Randy, were you going to say something?
No.
No? Oh, okay. So next question is, one of our colleagues is about to begin the development of an LGBT health center in association with the affiliated hospital. Do you know of, is there a good way to start, or is there a good contact or guide to begin this process? So basically, are you aware of other hospitals that have LGBT health centers? Because oftentimes these are affiliated oftentimes in universities and our research centers.
Oh, absolutely. Any number of large urban areas are going to have a LGBT health center, and for example, the Fenway in Boston, Callan Lord in New York City, the Whitman Walker, and the Los Angeles Gender Center. I'm leaving out a lot, but these are searchable online, and it certainly is possible to learn a lot and not have to reinvent the wheel. Fenway in particular has written a handbook, a textbook on LGBT health, and the Fenway Guide is available to order, and I'm sure that if a person wanted to make a site visit to see how it's done, that they would be most happy to arrange a tour for them.
Oh, that's great. Thanks, Becky. Maybe we could put a couple of those examples in the resource guide as a start. A resource list, I should say.
Certainly.
Okay, very good. And then also, too, Amy interjected that 2 years ago at the GLMA conference, she heard a paper on the transgender population in India. This goes back to our previous question. And so she's going to try to see if she can find it and include that in our resource list as well. So thank you, Amy, for that. Great. So now we have another question, and this one is regarding curriculum. So is there a curriculum guideline being developed for healthcare professionals while they're still in college or in their health profession schools, such as a segment of the coursework dedicated to teaching for future providers?
Well, I would invite that person to consider the GLMA conference, because every year we have several workshops or plenaries on that very topic, and this year we are having subjects. I think one of the things I saw early was the inclusion of LGBT issues in the nursing curriculum, and many medical schools have developed a very rudimentary, if you will, just a few hours of LGBT health. A few have much more than that, and the possibility of learning more about it, I do invite people to come to the conference and talk with the presenters there.
Okay, great. Thank you. Thanks for that clarification, Becky. And then also, too, thank you from Jameson Green. Backtracking to the issue of electronic health records, and you had mentioned Madeline Deutsch regarding the WPATH's EMR recommendations. Jameson Green mentioned that WPATH's EMR recommendations have been published in an article in the Journal of the American Medical Informatics Association, and will soon be starting a fundraising campaign to be able to purchase distribution rights to the article so it can be freely circulated without violating copyright laws. So that will be very, very helpful. So Jameson, I'll probably be touching base with you offline to see how we can get further information about that perhaps, and maybe perhaps support that. So thank you. Thank you for that clarification. We have a few more questions, so I'm going to keep going here. Let's see. There was a question of whether transgender individuals are at a higher risk for eating disorders.
Randy?
I don't know that there's a higher risk per se, but I know that there is a significant prevalence of eating disorders, and again, it's more common with young people, but I don't know how it compares to the rest of the population.
Okay, great. Thank you, Randy. We have another question. So since we have the GLMA provider directory, the person was wondering, are any of you aware of the eligibility requirements for an individual to participate? Is it a matter of just you go in and you complete a form and you're included, or is there a vetting process? How does that actually work, if you're aware?
There is a form to complete, and on the GLMA website, there is the opportunity for a provider to add their listing. There is a dialogue that goes on then with the GLMA staff, once the person has certified that they are, number one, willing to treat LGBT persons, and number two, have some degree of expertise, and they are added to the site.
Oh, great. Thank you. So we'll, in our resource list, we'll also include a link to that as well. Let's see. So we have another question, and it says, are you aware of any lists or national clearinghouses for LGBT sex worker friendly medical service providers? Now, understanding that this is dependent upon access to insurance benefits and consistent care, Do you have any advice for LGBT sex workers who are seeking medical services?
For sex workers who are seeking medical services?
Yes, correct.
Well, I think that WPATH maintains a list of providers, and their specialties are listed. And so we have people who identify as sexologists and people who, list their professional affiliation. And those are also listed geographically. So that might be a good point of departure for somebody who is looking for an appropriate caregiver.
I think possibly the best advice I would give now would be to look at these urban LGBT health clinics that we mentioned, because that's a large part of what they do.
Oh, great. Thank you. Thank you, Randy and Becky. And then back to the, again, we're getting comments in relation to previous questions. So Allison Royce was mentioning that the Human Rights Campaign Healthcare Equality Index for 2013 is also a good resource for facilities with LGBT care as well. So thank you for that suggestion. And let me see, I think that might be, oh, this is great. So we're pretty much ending on time. Let's see if anything else just came in. Oh, wait, we have a couple more questions, and then we will end the webinar. So similarly to the last question, Becky mentioned trying to find transgender educated providers, but basically we get no transgender education in our training programs. This was the curriculum issue. This person is actually on the faculty subcommittee at GLMA, and we are working to find, share, and disseminate health professions education materials. Any ideas on how to share existing materials is appreciated. And I know, as Becky mentioned, I know when I was at GLMA last year, I attended several panels and sessions that had to do with curriculum development, since I work in a school of public health and work with medical nursing and public health students. So, of course, I'm eager to get that kind of information as well. So, Becky, Randy, or Amy, do you have any ideas on how to share existing materials? Would perhaps the GLMA website be a repository? Is that something our Cultural Competence and Education Outreach Committee could consider, or?
Becky, yeah. I don't know if you want me to answer this or not.
Go ahead.
If you want to go ahead and answer this.
I can, as a GLMA board person, I do think that this is in the purview of GLMA's mission, and I think that we certainly would take materials that have been developed by GLMA members and under the GLMA aegis and want to share them perhaps as a part of the GLMA website, and also just by putting out appropriate email blasts. We have a large email list, for GLMA, and also through social media, and just tell people, these resources are available, and here's where you can find them, download them.
Yeah, and I would just add that we have begun collecting some of that information. So there's a start. I think it wasn't, I'm not positive it was GLMA specifically or solely who was collecting some of this information, but I think I know that we do have some, a somewhat robust repository of some of that. So I think also we can certainly follow up on any information that we can share about the best ways to get that information circulated.
Oh, great. Excellent. So we have one last comment, and this is from Jameson Green. Thanks, Jameson. Just wanted to mention that the primary care protocols are available from the Center of Excellence for Transgender Health, which is at UCSF, U of California, San Francisco. Jameson provided a web link, and we will also include that in the resource list. So thank you very much for providing that. And being that there are no further questions, I would like to, oh, actually, there's a ton more questions, but we've run out of time. So what we will do is, Randy, Becky, Amy, there aren't a ton of questions, but we can take a look at them, and then maybe we could put a document out on the website with this stuff, like kind of the answers we had, and perhaps answer the handful of questions as well, perhaps. We
Sure.
received great feedback. Great job, Randy and Becky. I learned a lot. We do really appreciate that. And then another comment too is, this is a good comment from Kristen Ekstrand, Med Ed portal, which is really based towards curriculum development for the allied health profession schools, does have a repository of curriculum materials that is peer reviewed. So that might be another avenue as well. So doing it via GLMA. And Reese Malone, this was the question about sex workers, provided a link to stjamesinfirmary.org, which provides healthcare for sex workers in San Francisco. And another suggestion was reviewing ester data out of Pittsburgh. That's Ariel Dance. And Becky, you were asked to restate the name of your website, please. And I think you just said it was Dr. Becky, DRBECKY.com. Is that correct?
That is correct, drbecky.com.
Right. Okay. And then again, some of these aren't questions at all. They're just suggestions. So this is great. For the curriculum piece, a suggestion was look at the Association of American Medical Colleges, or the AAMC, LGBT and DSD Patient Care Advisory Committee guidelines, or speak with Vanderbilt University's program for LGBTI health. So again, these are great suggestions that we can include. And let's see, Keisha Bennett, who's co-chair of the faculty subcommittee of the education committee at GLMA, asked the person who is concerned about curriculum and such to please consider joining that committee. And I think, yeah, go ahead.
Oh, I was just going to, this is Amy. I just want to thank that person for making that plug, because I was going to make the same plug for anybody who's interested in joining our education, cultural competence, and outreach committee. So right. As we continue to put together webinars, but yes. And I also did want to say that I believe the two, the MedEd portal folks and the folks at Vanderbilt, I believe are going to be at the GLMA conference. And I believe that there is a session that's going to be presented on curriculum education. So
okay, excellent. And then, oh yes, and that was a question. Someone just asked, how do people go about joining committees?
Do we have our GLMA information on the website, or do we have actually, I think it would probably be helpful to give some email addresses. So if you're interested in any of our education committees or others, I'm happy to give you my email address, because I'm at the top of my head. I'm not thinking of Emily Kane Lee's email address, but it is alwstronks@gmail.com. But we will also make sure that we put that information in the resource information.
Okay, great. We also had a question too, because this is part 3, we do have access to parts 1 and 2. They are on both of our websites. So when we send that email out to you after the webinar, that will be posted. And yes, the question was, can we please post the responses to the Q&A? So that's fine. I can listen to the webinar recording and do that. That would be fine. And I believe that is it. I'm just looking at one last thing here. Oh, yes. And the one other item too, and I think you mentioned this, Becky, perhaps, when you were talking about probably part of health maintenance. And this was a person had mentioned too, the higher risk for obesity in lesbian women.
Yes, that is true. And there's been a lot written about that. And other than the subgroup with the polycystic ovarian syndrome, there's no clear determinant of why lesbian women have higher incidence of obesity, but certainly activity has something to do with it, and we are continuing to have a lot of research on this very topic at our GLMA conferences being presented.
Excellent. Great. Well, being we have no other questions, and I'm amazed we were actually able to get through that many questions as well as feedback. So it's great because the feedback that was provided and the commentary was also helpful. So I would like to thank our presenters, Randy Etner and Becky Allison, as well as Amy Wilson-Stronks, for helping us to put together a quality webinar. And I'd like to thank everyone who joined us as well. This is very exciting for us. In the hour prior to the launch of this webinar, we had 445 people registered, and we've had 265 people actually participate in the webinar at some point live. So that's really an overwhelming response. And I know a number of people had emailed me before the webinar stating that they had developed conflicts and would this be available. So we're hoping other people will listen as well. And so we thank you for your time and tune in for when we schedule part 4 of this webinar series. So I hope you all have a great rest of the afternoon. Thank you.
Thank you.